Hi, this is Larry Bauer, Chief Executive Officer of the Family Medicine Education Consortium, and I'm talking today with Dr. Paul Frame, a clinical professor at the University of Rochester in the School of Medicine and Dentistry, and also a family physician with Tri-County Family Medicine. Paul, it's so good to be talking with you this morning. Thank you.
Good to be here.
So, Paul, I want to take you back to your beginnings. Where did you come from? Where did you go to medical school and residency? Can you give us a little background?
Well, I grew up in East Lansing, Michigan, which is a college town, home of Michigan State. My dad was a math professor. My wife and I were high school sweethearts. I went to Oberlin College in Ohio, and then to med school at the University of Pennsylvania in Philadelphia. How I got into family medicine is rather perhaps interesting in that the University of Pennsylvania actively discouraged anybody from going into primary care at that time. There was no exposure to primary care, no exposure to family practice. They did have a community medicine rotation, which lasted 2 or 3 weeks and included public health and all that type of stuff, as well as they gave us one day in an office of 3 different doctors. And I spent one day with Bill Ryle, who was at that point practicing in Swarthmore, and he later became president of the AMA. I spent one day with Frank Snope in Lebanon, New Jersey, who later became my residency director. And I spent one day with Paul Brucker in Abington. Paul, of course, became president of Thomas Jefferson University later on. And each of these guys were doing full-time family practice, admitting to the hospital, were loved by their patients. And I said, that's what I want to do. And so it was those 3 days that got me into family medicine instead of doing anything else. Then
so
I did... Yes, go ahead.
Well, I was going to say I had the great pleasure of meeting both Frank and Paul, and that's an impressive 3 days, honestly.
Yes.
Wow.
Yes. I mean, those were not your average run-of-the-mill docs, but it was extremely fortuitous because it had quite an impact on me. And then I did my residency in family medicine at the Hunterdon Medical Center in Flemington, New Jersey, which at that time was a bit of a unique place. It was only a 150-bed hospital. We're talking now 1971 that I started my residency. 150-bed hospital. All the specialists were on salary, and all the community care was done by family doctors. So it was a very sort of unique kind of setting, and of course perfect for family practice.
And that was referred to back in the day as the Hunterdon model.
That's correct. That's correct.
That's
and it
great.
was a wonderful model. It was a wonderful model.
So
how
I'm wondering
I got
if you
into... Yeah, go ahead.
Well, I was going to say, now you're at Hunterdon, you're a resident, and I'm hoping that you can tell us the story about how a resident project really revolutionized primary care.
Well, this is interesting, too. The hospital had health screening clinics, as many hospitals do. Actually, if we're honest, the main purpose of these clinics is public relations, not improving people's health. But the residents used to participate in these clinics, and we would do blood pressures and urinalyses and Shiatz tonometry and maybe a CBC and a CMP and different things like that. And one evening after one of these clinics, we were sitting around talking, and we asked the director, why do we do the tests that we do? And his answer was, what else would you do? So that was the state of the science as far as preventive medicine goes back in those days. And of course, the dogma was that everybody should have a complete annual physical exam, which nobody had really defined, and there wasn't time in the day to really do. So one of my other residents, friends, Steve Carlson, I very distinctly remember I was coming off call and going rather slowly up the stairs. He was fresh from a good night's sleep, came bouncing down the stairs and said, Paul, we should look into this issue of what screening tests make sense. And after a little bit of you're crazy and, what do you think we're doing, we decided to do it. Fortunately, there was a librarian who was underutilized and had lots of time. And so we just sort of sat down and started looking at all the possible things you could include in a preventive examination, and then looked at the evidence for whether they made sense or not. Fortunately for us, at that time, the evidence was much smaller than it is now, but it was still a rather sizable project, and we were extremely naive in terms of knowing how to write research papers. We submitted after about 2 years of work, just before we were finishing residency, because we knew if we didn't get it done before we left, it wasn't going to get done. We submitted I believe, 150-page manuscript to John Guyman at the Journal of Family Practice. Now, of course, 150-page manuscripts for a journal article are unheard of and totally out of the question. But the Journal of Family Practice was a new journal, and Guyman saw the potential and said, we'll do it in a 4-part series. And so it was published as a 4-part series in 1975. Got some attention within family medicine circles, but I would say very little attention outside of family medicine circles until 1979, when the Canadians formed the Canadian Task Force on Preventive Services. And in their initial papers, they referenced our articles extensively. And, that sort of put us on the map and got us a little bit more recognition in the wider medical community. By that time, I was had, of course, finished residency and was in rural practice in Cohocton, New York, and Steuben County as part of the National Health Service Corps. And actually, that's where I've stayed ever since throughout my practice career until I retired in 2009, or mostly retired. I'm still doing a little bit. So, but that was the early story. And then,
so I recall the excitement, Paul. I recall the excitement when I came across those articles, and I started with Penn State Hershey in 1978. So as the department began to look into preventive services, came across your materials, and as I recall, you were invited to come as a speaker. And just really impressive how you had put together the criteria for judging preventive services and in building the case of support that you did.
Right, and it was interesting too, in that we stepped on a lot of toes. First of all, we said the complete annual physical is not feasible and not worthwhile. That was somewhat heresy. We said that routine EKGs were a waste of time. We said that routine blood work was a waste of time. We said that there was a manageable core of procedures which made sense and should be offered to everybody, and those included things like blood pressure screening, lipid profiles, pap smears for women, and mammograms. Although mammograms were not terribly common back then, but they were around, and there was at least one, the New York City trial from the 1960s showing benefit. So we had a handful of things that did make sense and a whole bunch of things that didn't make sense that we said should be discarded.
And can you describe how from that point, at some point, we get to the U.S. Services Preventive Task Force?
Yes. Well, that was one of these interesting serendipitous events, too. In the early 1980s, I was feeling very frustrated. Here I was in full-time rural practice, quite busy, and felt that the articles definitely needed to be updated. But I felt that I didn't have the time or the resources to do it, and I even toyed with going into full-time academia, thinking probably falsely that I would have more time. But anyway, I was stewing with this frustration, and it turned out in Rochester, at the University of Rochester, there was a Surgeon General's conference on breastfeeding, and Ruth Lawrence was in charge of this conference. Everett Koop was the Surgeon General at the time, and he was coming, and all the big muckety-mucks from Washington were coming. And Ruth Lawrence realized at the day before the conference that she had no family doctors anywhere on the program, involved with the program, etc., and that this was politically a mistake. So she called me up and she said, is there any way you can come to this conference? And, we need some family medicine representation. So I said, okay, I'll come. And at the conference, I met Mike McGinnis, who was head of the Office of Health Promotion and Disease Prevention, and was forming this group called the U.S. Preventive Services Task Force. So I said, wow, this is perfect. And I had received requests for my articles from Mike's office. I didn't really know what the context was, but, you used to receive a lot of requests back in those days, and I had sent them off. So they were forming this new task force. So I really lobbied to get on it, and talked specifically to Harvey Estes, who I knew, who was one of the people forming this group. And Harvey said, well, I did submit your name earlier, but they had sort of already decided, who was going to be on the task force. And so the long and the short of it was that they did not put me on the task force, but they made me a senior advisor to the task force. And actually, to be honest, that pissed me off. And, I realized that I knew more about this stuff than any of them did. And it sort of gave me the kick in the pants to say, I'm going to update those articles and I'll get them published before they ever do. So I did. and it was a lot of pockets full of nickels going to the Xerox machines up at the library in Rochester, and then not bothering to read the articles there because I didn't have time, but bring them home and read them. And there was a lady at our hospital. The administration was very nice. She had this newfangled device called a word processor that I knew would be very helpful, and so I was given her services. And through basically just a lot of late nights and weekends, updated the articles, and they were published in 1985, which was 4 years before the first edition of the Preventive Services Task Force materials were published. And the second thing that happened was the initial task force was a fairly inefficient group, and they didn't really get through most of the topics they were supposed to do, and so it was left to the staff to really finish the rest of the first report, which was Steve Wolf and Doug Camero. And by that time, we knew each other quite well, so that Steve and Doug and I, although they were doing most of the writing, I was giving them lots of advice on, different topics from the work that I had updated in 1985. And so that was sort of the initial task force I didn't get on, but it gave me the kick in the pants I needed to update the articles. And then, of course, when the task force was reconstituted in 1992, they did make me a member of it. So that was very nice because it was a much easier structure to work in and continue the work that we'd been doing before.
So the U.S. Preventive Services Task Force has become one of the most prominent counterweights to the overuse epidemic that we have in this country. And I think it's pretty impressive, actually, that it started off as a resident project, and now it's quoted in the paper, it's quoted very broadly by the media when there's a controversial, whether it's prostate exams or PSA testing, that kind of thing. So all I can say is kudos to you and to the group that formed that decided to deal with some of the holy cows.
Yeah. Well, it was, and in retrospect, I'm frequently sort of surprised too. So I certainly know that I think, people always ask, well, how did you do it? And I guess that just comes from, when you have the fire in your belly and you really want to do something, you can make it happen. But we were very lucky too. I mean, there was a huge chance that our original articles would not have gotten published, had it not been for John Guyman's insight. Right. And also probably, quite frankly, the Journal of Family Practice needed material. They were a brand new journal. And, they were looking pretty hard for, substantive material. So that was a set of circumstances that sort of just was lucky. And also, like I said, this breastfeeding conference in Rochester where I met Mike McGinnis was lucky. And so there were other fortuitous events along the way that sort of allowed things to go the way they did.
So when I get a chance to talk with folks like yourself, Paul, who were very active and had fire in the belly, as you say, back from the day, there's always the circumstances where one thing led to another thing, and but it's that I do think it's that vision, it's that determination, it's that getting pissed off that energizes you, and I just think it's really a powerful story for the younger folks today who oftentimes perceive that there are obstacles, that there were always obstacles to things, but I think that if you have the energy and the determination, you can deal with those obstacles.
Yep, there are certainly lots of cases throughout history and throughout family medicine that's true.
So, Paul, do you want to give us a sense for then what's happened to you now, kind of bring us up to the present for you?
Well, on a parallel track, and this drops back again to 1974 when I went into practice, I realized that, we'd written these articles about here's what you should do and you should offer it to everybody. And if I'm in practice, maybe I should actually try to implement this stuff, or somebody might come and say, well, gee, you wrote these nice articles. What are you doing? So
good point.
That led me down the second path of how do you actually implement prevention into practice. And we started out with paper flow charts that we would check off, and realized that although that was certainly better than nothing, and at least we had a framework, that it wasn't, you really need reminders and prompts. And that led us to thinking that maybe a computer-based health maintenance tracking system would work better. And so we got bold, and in coordination with the folks at the Department of Preventive Medicine at the University of Rochester, submitted an R01 grant to the agency for, AHRQ is what it is now. I think it had a different name back then. This was in the early 90s. And so we submitted this proposal for a grant, and Jennifer Mayfield was the point person at the agency at the time, and she was very supportive. But it's very hard. It's not easy to get grants, and so it wasn't quite making the threshold until one day she called me up and she said, I think we've got the answer. She said, the agency is really looking, all of our research comes from academic centers. We get no research from rural areas, and yours is a rural project. Of course, it's just as applicable to urban environments as it is to rural, but it happened to be coming from a rural. So she said, I think we can put this through as a rural grant and get it funded. And she did, and that worked out. And that led to the next sort of phase where we were able to compare a computer-based reminder system with the old manual flowchart system. And as you can guess, the computer-based reminder system was superior. And that has, of course, nowadays evolved with the electronic medical record to being, checklists and things that people fairly routinely have a protocol of things that they're trying to make sure get done on a regular basis. So that was the sort of second arm of the whole thing was, okay, you've got these recommendations, how do you implement them? And that was a lot of fun, too.
It's fascinating. I wasn't aware of that second track. In some ways, how that's being used in the current electronic medical record creates some real tension when, I guess you could say, when it gets overdone and
absolutely
a little too prescriptive. But it certainly seems like a very positive step forward at the time.
Well, we used to have the same problem you have priority issues that you really want to focus on. So I can remember, for example, smoking cessation was always a big priority. And so people said, well, we'll put stickers on the charts of everybody who's a smoker, and that'll remind us to prompt them to quit, or, at least ask them about it. And that works fine. But then somebody else would say, well, flu shots are very important and mammograms are very important. And if you have one sticker on a chart, it prompts you to do something when there are 10 or 15 or 20 stickers on the chart, which is
right.
what we have with the electronic record nowadays. Then they do lose their impact when you've got such a huge number of things that you're supposed to be reminded of, which I guess gets back to the importance of really picking and choosing the things that are important and focusing on those, and getting rid of a lot of the sort of marginal ones.
Exactly. Good point. So, Paul, I want to bring things to closure here. Any final points when, let's say, you're speaking to the folks coming through, medical students, residents, young family physicians? Any words of wisdom from your experience that you'd like to pass along to them?
Well, I guess possibly two things. Number one, I can't think of a better way to spend your life than practicing family medicine. And the second thing that was most important to me in practice doesn't necessarily have anything to do with prevention, but there's a little frustration when you're coming out of medical school that everything doesn't go quite as you planned in terms of patient care. And once I got it through my head that my job is not to cure people, but to care for people, it made life a whole lot easier and a whole lot more satisfying. Because sure, occasionally we do cure people, but for the most part, we don't. And maybe we postpone things. But the caring for people is what's really important, and that's what sets family practice apart.
Paul, thank you very much for spending time talking with us today, and thank you for your contribution not only to family medicine, but to improved health in the United States and throughout the world.
Well, thank you. It's certainly been a pleasure.